I'm Jo Williams. I'm the Director of the Welsh Sexual Assault Services Programme, and I will be taking you through the event programme today. Just before we start, if we can have some general, I'll just run you through some general housekeeping rules. If everybody could please turn their cameras off and put their microphones on to mute. The session today is going to be recorded, and the chat box is going to be open for any comments or questions that you'd like to ask during the presentations. And we can also do questions post the speakers if anybody would like to ask. So our session today is best practice in forensic medical examination, and we've got a lot of speakers today who are going to be taking us through the forensic elements. So it's just a brief run through of the morning. You'll have to excuse me. I'm suffering a little bit today, so if my voice goes, you'll just have to bear with me a little bit, I'm afraid. So running through today quickly, Yasmin Khan, we're unsure if she's going to be able to join us at the moment. She may join us a bit later on, but currently she's unable to come on to the session. So we'll be kicking off with Dr. Catherine Simpson and Dr. Claire Thomas, who are going to be giving us a session on demystifying the hymen. Then we're going to be going over to Dr. Claire Lepetz, who's going to be talking to us about care of the victim. We then have Natasha, who is a survivor and is going to be giving us the survivor perspective and experience of services. And then to finish off today, we're going to be hearing from Dr. Deborah Hodes, who's going to be talking to us about FGM and the physical signs. The event today is going to be quite emotive, and anybody can be affected. So if you are affected by any of the content of any of the presentations, the Live Fear Free helpline is behind me and will also be posted into the chat bar. So please feel free to leave the session and or contact the Live Fear Free helpline if you are affected by anything that you hear today. The number is 0808 8010 800. There is also a Twitter hashtag for the series of learning events, which will also be posted into the chat bar. That's WSAS Learning or Dusky Gurk. I'd like to just say thank you to everybody as well for switching this event over to online. What we're planning on doing is holding a further event in June, which I'll give you a bit of detail about at the end of the session, which is going to be an in-person event, very hopefully. So we'll kick off today then. So I shall pass you over to Dr. Catherine Simpson and Dr. Claire Thomas, who will be giving us our first presentation of the day. Diolch, thank you everybody.
Hi, good morning everyone. Claire and I are doing a double act on this, and you may pick up that we haven't rehearsed this, so there'll be an element of us handing back and forth to each other. But what we're hoping to do is talk through the hymen and some findings and a revision of normal, really. So I'm Catherine Simpson. I'm a paediatrician based in Cardiff and Vale. I'm the clinical lead for NFSAF SARC, and I've also got a role within the Welsh Sexual Assault Services as a paediatric lead. And then I don't know, Claire, if you'd like to introduce yourself as well. Oh, you're on mute, Claire.
That's a rookie mistake for the beginning. I'm Claire Thomas. I'm a consultant paediatrician, but I am also one of the designated doctors for the National Safeguarding Team, and I will also work with Catherine at NFSAF in the SARC.
Fabulous. So if we move on to the next slide, please. So what we're hoping to do today is as you can see, so learning objectives. So starting off with an anatomy revision, and many apologies if it's things that people already know, but I find myself that I'm constantly revising all these things. So hopefully it's not something that's not useful. Having a little chat through the normal prepubertal and postpubertal appearances, having a chat through examination techniques, talking a little bit through the terminology that's used in reports, a little bit on interpretation of findings, and also discussing a bit of the limitations to an examination. So next slide, please. So I'll move on, let Claire present this a little bit.
So having looked at all of the, we've just seen all the slides for the whole morning, and I think everyone's definitely going to know their anatomy by the end of this morning, because I think nearly all of us have included this in our talks. But I think it just really shows how important it is that we all know exactly what we're talking about when we refer to different parts of the anatomy, and particularly important for when we're writing reports, so that they can be explained in court and to perhaps non-medical members of the multidisciplinary team. So I can't actually use my pointer for this, so I'm just going to go through the labels from the top down and try and explain to you where the different ones are. But you can see at the top of the picture, there's the mons pubis. And then just moving down, you'll see that there's two arrows, which refer to the labia majora. So that's in that's plural, and so they would both be the labium majus if they were being referred to in singular, say if there was an injury to one or the other of them. Just moving slightly down, you'll get to the pink part of the diagram, and you'll be able to see the clitoris, which is the small sort of P shape part that you can see in the middle of the pink area. Moving straight down from the clitoris, we've then got the urethral opening, or the urethral orifice, where the urine will come from. If we move to the right from here, we've then got the labia minora, which is the plural. So if we need to think about it from an injury perspective, or describing one or the other of them, then we would call them the labium minus. So those are the two pink, the sort of sides of the pink circular area. If we just move to the left, the whole of the area is within the pink area is referred to as the vestibule. So that's just a useful thing to know, that anything within that area is known as the vestibule. But that only goes as far as the hymen, and so I can just move on there, and if you can see right in the middle, surrounding the inner pink area, that's the hymen. It's sort of dotty on here. So the vestibule takes up all of the area up to and not including the hymen. And we're going to talk a lot more about the hymen in a moment. But I can just show you that that's there. In the centre of the hymen, we've got the vaginal opening, and the vagina starts at the entrance of the hymen and then goes right the way up until we get to the cervix. We've then got the perineum. So there's a couple of bits actually which aren't actually on here. So another important bit to know about. So if you look at the very bottom part of the pink area, the pink circular area, this ring-like area, the very back of that is the posterior fourchette, and then the area between the posterior fourchette and the anus is called the perineum. And then the only other part, which I think would be really important for people to know about, the area between, it's very difficult doing this, describing rather than using your pointer, but if we look at the area from the back of the vestibule to the posterior fourchette, so that little cross section of the back of the ring there, that's the fossa navicularis, and really those are the main parts that you'll need to know when you're considering when you're writing a report or describing injuries. So if we just move on, please. So what is the hymen? Well, we've got quite a mixed audience today, so some of you will know a lot of this already, and some of you may not know it. So apologies if we're telling you things you already know, but it's really important that we all, as police, social workers, doctors, nurses, that we all have the same terminology and the same understanding. I think it's particularly important, really, for those people who will be talking to the children about, and the parents about, having a sexual abuse examination, because I think the thing is, often that's the first contact they'll have, and often this really colours how they feel about the examination, but it also colours their expectations of what we'll be able to tell them, what information we'll be able to give them when we see them. And a lot of, Katrin and I probably would agree that a lot of the time that we spend talking to the families is often demystifying, as the name of our talk is, you know, some of the things that the parents, the families' expectations and understanding. So what is the hymen? Well, as you've seen a picture of it, or a line diagram of it already, it's a membranous piece of tissue at the entrance to the vagina, which surrounds the hymenal orifice. What it isn't is a membrane which goes right across, which can then be broken. People sort of imagine that it's almost like a piece of cling film which can be popped, or you know, which can be, you know, intact and then can be burst or popped, and obviously that's not right. One of the things that people ask us all the time is her hymen intact? Now, obviously, that comes really from the previous ideas that people have a hymen which can be burst, or through penetration can then, you know, sort of you know, pop or break, if you like. And so I think it's really important for us to be able to explain to them what the hymen's like, but also that by examining them, you know, if you examine the child, it doesn't necessarily mean that if the hymen has no injuries, nothing happened, but it also doesn't mean that you know, we just have to demystify the fact that you can't say whether something is intact or not intact. Can it be damaged? Absolutely. And a lot of what we'll be talking about today is different damages and different signs of that. The prepubertal and pubertal hymen look really very different, and they are actually very different as well, because of the hormonal changes, and Katrin's going to talk about that as well. The prepubertal hymen is much more like the picture that we've already seen, which is a sort of stretched out, taut, circular sort of ring, if you like. And it's also got lots of innervation and can be really very tender and very sore to touch. The pubertal hymen becomes much more, with the appearances changing with age and hormonal influences such as estrogen, then your hymen becomes much more sort of folded and much more, I suppose Katrin and I often describe it as a scrunchie. When I'm in court, sometimes I take a scrunchie along to sort of show to the jury that actually it sort of becomes folded, and you know, that's really to enable it to be much more stretchy. But Katrin's going to talk to you about that more, so I'll pass you over to Katrin.
So next slide, please. Thanks, Claire. So this is just a quick reminder that when we're talking about the hymen, we often use sort of a clock face description. So if you think back to that diagram that Claire's already showed you, with sort of the child lying face up, or with the mons pubis sort of superiorly, so upwards, and the bottom downwards, then towards the top, where the sort of, you know, towards the urethral openings would be 12 o'clock on the clock face, and towards the bottom would be 6 o'clock on the clock face. It's worth noting that in some of the literature from the States, they change their clock face description depending on which way up the child is, whereas in the UK we tend to keep it with the anatomy rather than changing over. Sorry, I apologise. I'm noticing my camera is clicking on and off, so as long as you can still hear me. I think I need a new webcam. Next slide, please. So as Claire said, we've already, there's a huge difference within what the hymen looks like over the course of time, and the same person, same child, may have different appearances if examined at different points of their lifespan. As you say, a lot of these changes are influenced by estrogen. So when you have young children and babies, they often still have the influence of maternal estrogen, which impacts on the appearance of their hymen at that point. And then as a young girl goes into puberty and their estrogen increases again with the onset of puberty, that has an impact on the appearance of their hymen at that point. As Claire's already alluded to, the prepubertal hymen is highly sensitive, so that has a huge impact on our examination techniques and swabbing, and actually how, whether you can get anywhere near it with a swab, and obviously not wanting to cause that child any distress. And also important to note that in the research, there's no evidence of a congenitally absent hymen. There are some rare differences in genitalia genetically, but nothing that's just just an absent hymen. So next slide, please. So this is a picture of the most sort of common prepubertal hymens. So the first picture, which is sort of annotated A, is what we would call an annular hymen, which is donut shaped. You've then got crescentic hymens, which is what we're seeing in oh, sorry, actually on that picture, I think that A is meant to be fimbriated, so it's not the best thing. Sorry, B is meant to be annular. So donut shapes with the hymenal tissue being present all the way around the clock face. And then in the picture C, there is what we would call the crescentic hymen, where there's an absence of hymenal tissue to the anterior portion. So if you were talking about the hymen, the clock face description, say, there's an absence of hymenal tissue between 11 and 1 on that picture. And that can vary. So if you do see a crescentic hymen, then ideally it would be good to give a description using the clock face to say where there's an absence of hymenal tissue present. Next slide, please. There are less common appearances, and I have to say that myself, I've not seen many of these ones. So a sleeve-like hymen is quite difficult to describe without a photo, to be honest. So that's a limitation for today. But if you can imagine sort of like that, a sort of the donut shaped, but with it sort of projecting forward, so almost making like a tube. Like one sleeve. That's an appearance that we do see, and that can again be quite difficult to visualize, and Claire will maybe talk through some of the strategies that we use for trying to help with that. Sometimes you have a septate hymen, which is where you've got a piece of tissue that is dividing the hymenal orifice, and in those cases it's important to see really whether that's just the septate hymen or whether there's any sort of issues higher up. You can have, again, some sort of congenital differences. And so it might be a child that may require some further investigations for that. You also have cribiform hymens, which have got lots of tiny little holes in, microperforate hymens, which just got a very tiny hole, and you can also have imperforate hymens. And again, these are sort of more unusual presentations, and in things like the imperforate hymen, it may only be that is picked up with when menarche, when periods don't start. Okay, next slide, please. And that's, sorry, it's a busy slide. I don't know how well it's sort of projecting, but that's just showing you through a longitudinal study where children were examined at different stages of life, and just again showing how the appearance of hymen can change in a child over time. So just showing sort of in the newborn, you're looking at 80% of children present with an annular hymen, and by the time you're getting towards sort of 9 years of age, 90% are crescentic hymens. So that's just quite helpful to sort of realise. Okay, next slide, please. So here's the famous scrunchie. Anybody who's sort of my era of growing up as a 80s, 90s child had these scrunchies, but I think they're back in again now anyway. But it's just a helpful way to sort of understand how when the hymen becomes fimbriated with all these folds, it's actually quite difficult for us to be able to visualize the whole thing in one go. But the plus point being normally by the stage you have a child who's got a fimbriated hymen, that the sensitivity is less, and that allows us then to use various techniques to try and visualize the whole of the hymen. And so next slide, please. There we go. So I'll pass back over to Claire.
Thank you. So when we examine the children, it's again really important that we write in the report and we explain to everybody how we examined them and in what area, in what way we examined them. So for prepubertal children, the main way in which we tend to examine them is with lying on the bed, and then we normally say to them, bend your knees up, so that the knees are bent with the feet on the bed, and then you just say to them, can you flop your legs apart like a frog? And most of the children find that absolutely fine, and usually their feet will then be together, and that's the description of that as the frog leg supine position, and again important just to reference that in your report, or to be able to explain to people. So that's a useful. So that's the main way in which we tend to examine. Sometimes you don't get a brilliant view with little ones doing this, and actually in most of the prepubertal children we would also do what's called a knee chest prone position, which is when you'll ask them to get onto their hands and knees with their bottom facing you on the bed. And in this position, it's amazing sometimes when you are trying to examine a child and you really just can't quite see and you can't quite get a good view. Sometimes things just come into view much better, obviously remembering that the anatomy is then completely upside down. So when you're writing a report, it's always important to remember that that we know about the clock face, etc. And as we say with the English terminology, the clock face remains in the same place regardless of what position the child's in. So the children, it is a slightly unusual thing, but the children generally are good about it. I think it's about getting a rapport with them first, explaining what's going to happen, making sure that you've got that you're being friendly and making them sure that they know that they can say no at any point and they can stop the examination. Many of the little ones are very happy and they almost don't really know that you're examining them when you do that. Perhaps mum's talking to them at the head end of the bed. But it's really a very useful addition to the examination, particularly when you can't see. So that's recommended for most of the prepubertal examinations if the children are happy to let you do that. Then the way in which we actually examine, the first thing is to try labial separation, which is literally just taking hold of the labia majora and then just pulling them laterally or pulling them aside, which this will allow everything to open up. And that's often all that you will need. But sometimes we also need to use something called labial traction, which is when you actually pull the labia majora out, but you also pull them up. So it sounds, it doesn't hurt, and it's just a sort of traction. And what that does is just stretches out the tissues to enable us to get a better view. As we've both mentioned before, and so important for everyone to remember, the prepubertal hymen is extremely sensitive. So we can't use techniques that we might use for postpubertal children to try and delineate the hymen or to get a better view. And it's our most important thing in the examination is not doing harm and not hurting the child, as they've already suffered. So what we tend to use is something called floating, which can sometimes be really very helpful. And when we do the in-person event, we can show you, there's some quite good pictures of floating where you can see exactly how it can really help the hymen, just to sort of, it just starts to show it a bit better. And floating is really when you just get some sterile water in a syringe and you just drop that onto the hymen, and it just enables the hymen just to sort of straighten out a little bit, and sometimes can be all you need to be able to get a better view. So next slide, please. So post-pubertal examination techniques. Obviously, these are quite different. The children are much more able to understand, and you can really do an informed consent and really in many of these children and be able to talk to them about what's happening. Again, most important that they know that they can stop the examination at any point. If they're not happy, if they're worried, they can restart, or they can just completely stop, because making sure the child is okay is the most important part of our job. So postpubertal girls, it's really a lot more difficult, as you probably realise from our discussion about the scrunchies and things like that. And if you just look at plain observation, you will see some. You might see some information, but often what you see is like a hint. You might see something which looks like it might be a laceration or a transection, but actually it's almost impossible to be able to see that without looking further. So again, sometimes we use the sterile water again. Sometimes using the flooding might help as well, just particularly if things are stuck together with some discharge and things like that. Sometimes we'll use a swab, just one of the usual swabs that we would use for when we do the STI testing, and that's really just to carefully tease out the folds of the hymen and be able to look to see if there's a continuous border all the way round, and that can be really quite helpful. But also you may find if there is a transection, then sometimes the swab just sort of slips into it and you can see, but it also helps to be able to see how deep the laceration might be, whether it's full thickness or whether it's more than 50% of the width. So that's often a useful technique to use. I have to say, the thing that I use the most when I'm examining postpubertal girls is actually a catheter. I find that this is the way that I can get a really good view of all of the quadrants of the hymen. So we just use the same sort of catheter you would use for urinary catheter. I usually take the catheter out and I show them. In fact, sometimes I even take it out and blow up the balloon at the bottom of the catheter. Now, I'm just aware that some of the people here may not be medics, so you might not know. We should have put a picture of a catheter in at this point, actually. You may not know exactly what a catheter looks like, but basically catheter is the thing that's sometimes put into people's urethra to allow free flow of urine out of the bladder. And we use this for a completely different purpose. It's a long, thin plastic type tube, but what it does have is to enable it to stay in the bladder, it has a little balloon at the end which is not blown up usually. And so when you're putting it into the bladder or through the urethra, that goes in as a smooth tube, and then once it's in the right place in the bladder, you then inject some water through the end of the catheter or saline, which will then blow the catheter up, which means it stays in the bladder. Well, we do exactly the same thing for using this to look at the hymen. So again, you just pop it through the hymenal orifice. You don't have to put it in very far at all, because the balloon is right at the end, and it's usually only 2 or 3 centimetres of the balloon at the end. And once it's in and the child is comfortable, I normally just say to you, just a funny feeling, because it does feel strange. And then you just inject the liquid in the other end of the catheter, will blow the balloon up. And then what I tend to do then is I tend to use the balloon. If you pull back, you have to pull back not too hard, because sometimes it will just pop out. But as one very, very experienced FME once said to me, well, actually, that's a clinical finding in itself, because you can put that in your report that the hymen opened enough for a balloon of so many mils to be able to pop out. But if you pull back just very gently, what you'll find is that the hymen will unfold, and you'll be able to see all the different, you'll be able to see the whole area of it against the balloon. What I tend to do is I tend to maneuver it so that I can see all 4 quadrants of the hymen. So I will think, right, I'm going to look at the top left, the 9 to 12 o'clock quadrant first. So because it's sometimes difficult to see the whole thing in one go, and then I will do the 12 to 3, etc., making sure that you've really got a good view of all of them. And then at the end, often they will just pop out, but if not, you can just take the water out again and then take that out. use of a speculum is recommended. I have to say, particularly for the forensic examinations, I don't use speculums very often, and I think perhaps we always worry about using speculums in young girls, thinking, is it going to hurt? Is it, causing further trauma, etc. I have to say, the other day I did a medical with a very, very experienced FME who is actually a gynecologist, and the girl said to him, "Tell me when you're putting it in." He said, "It's done." And so actually, I think that was a real lesson to me, to say, actually, sometimes a very experienced person using a speculum so that you can get a better view, but also be able to take swabs from certain areas of the vagina, it can be done extremely effectively. So obviously, speculum is particularly useful for taking high vaginal swabs, and also for the forensic examination, and you do get a better view. Thank you.
So just moving on, just going to just talk a little bit about some terminology. This is something that's come out of so I'm going to talk about the Purple Book, and so the Purple Book is this book, which is the Physical Signs of Child Sexual Abuse, which is the evidence-based guide that was produced by the Royal College of Paediatrics back in 2015, and it's currently being rewritten, but it's sort of the go-to evidence for us when we write our reports. And so, if we stick to what's in the Purple Book, then you can't really go too far wrong, is kind of where we're coming from. And when they were doing the evidence-based review, a lot of the issues that came up were around the use of different terminology to be describing the same thing, and that obviously makes comparisons and evidence reviews very tricky. So one of the important things, which again I have to come back to, and I've got post-it notes stuck around my office to remind me to use the right words, is when we're talking about sort of disruptions to the hymenal membrane. So what we're talking about is when there are injuries present to the hymen. So we can either be talking about lacerations, and lacerations are what we call those disruptions when they're acute, so when it's a new injury. And it can be a laceration that's either partial, so it's only going through part of the hymenal membrane, or that it's complete, and that means it's going right down to the base of the hymen. But that's always, if it's acute, it's a laceration. When it's a healed or non-acute injury, then we're either talking about a notch, which can be superficial or deep, or we're talking about transections. So that's just something, as I say, if you're anything like me with a terrible memory, it's something that you stick on your post-it note and put it on your wall for when you write your report. So next slide, please. So this is my disclaimer, because the evidence in this Purple Book is huge and very nuanced, and I'm not going to claim to be able to whirl through it in the next 5 minutes. So if you are writing reports, always go back to the book, always reread it, because it's invaluable, really. And just to say as well, it's being currently updated, so there will hopefully be new updated evidence coming through soon. So next slide, please. So I'm going to go through these quite quickly, so that these are some of the sort of findings that potentially could be present. So bruising could be something that you'd see on a hymen. So bruise is a visible leak of blood into the soft tissue as a result of injury to blood vessels. We can't age bruising. Bruising has been observed with children who have experienced child sexual abuse, but also has been experienced in children with straddle injuries. So what we talk about straddle injuries are, for example, a child that falls with their legs straddling a hard object and causes injury to their sort of genital areas. So when we talk about straddle injuries, it's similar to when we are looking at bruising with respect to could it be inflicted injuries versus accidental injuries. It's all about the history taking, any observers, and does it all seem consistent? Bruising is more likely to be seen if we examine early, is the important point as well. Next slide, please. So an abrasion is another finding that might be documented. So that's a superficial injury involving only the outer layers of skin mucosa that does not extend through the full thickness of the epidermis. The epidermis would be the skin if you're talking about sort of something on the skin. So a linear abrasion is known as a scratch, and a brush abrasion is a graze. I hadn't realised that a scram was a Welsh term, and had been using that quite frequently in reports until recently. I didn't realise that was a Welshism. So abrasions can be seen both, again, in child sexual abuse and potentially straddle injuries. Again, it's all about that history and whether it's it all fits in with that with the findings. Again, it tends to be an early finding, and in the absence of a history of accidental trauma or consensual sexual activity in an older child or other medical causes, then sexual abuse should be considered. Next slide, please. So a laceration, so that's a wound made by blunt force splitting the full thickness of the skin or mucous membrane. So when it's acute, you might see bleeding or bruising at the edges of the laceration. The current evidence that we have is that hymenal lacerations have not been seen in girls who were examined who had been selected for non-abuse. They have been described in up to 33% of prepubertal children with a history of vaginal penetration, and between 3 to 19% of postpubertal girls alleging sexual abuse, including penile penetration. And again, I think that's a really important thing to note there is, so, if you're thinking about sort of prepubertal children who've given a history of vaginal penetration, only 33% are showing lacerations, the rest aren't. And that's, that's just, again, highlighting that sexual assault can occur without showing any injuries. So next slide, please. So that's just a sort of, again, little visual to sort of describe what we're talking about with these transections. So it's a discontinuity in the hymenal membrane. And again, you can see some pictures there showing the difference between sort of, what we call a deep cleft or a transection that goes right down to the base. And again, when we describe any of these injuries, it's about using the clock face, it's describing the depth, it's there may be more than one, describing whether it's got any bleeding points, things like that. So next slide, please. So transection is a sign of healed trauma. Again, they in the evidence base, transections have not been described in prepubertal girls selected for non-abuse. There was another study that did show one case where there was a prepubertal girl who showed a transection, but actually the authors do state that even though it was a child who was in the non-abuse part of the group, that they actually had concerns about that. But obviously we have to go with the evidence base really when we do our reports. Again, when we talk about transections, it's only 3 to 18% of girls who have alleged penile vaginal penetration who are reporting where transections are seen. And again, it's important to note that hymenal injuries can heal really rapidly and leave no residual findings. So what may have been, if you're examining as a cold case or a non-acute or historic child sexual abuse case, then there may potentially have been an injury if you'd seen them in the days after an assault, but when you're seeing them a month down the line, it may not be present. Okay, so next slide, please. And again, so clefts and notches, so these are sort of the little dips in the hymen, rather than something that's going right through to the base. So clefts and notches in the anterior hymen, so that's sort of the upper part of the clock face. have been described in newborns and prepubertal children selected for non-abuse. Superficial notches in the posterior part of the hymen have been described in prepubertal children who have experienced CSA and who have been selected for non-abuse. So superficial notches in the posterior rim, again, aren't really conclusive. But when we move on to sort of the deep clefts in the posterior portion, in a non-fimbriated hymen, they've only been reported in prepubertal girls who do have a history of vaginal penetration. So I appreciate this is huge amounts of detail and I'm going through it very quickly, but it's just to really try and give a little bit of an overview of the evidence that's there, and just to really highlight the level of detail and why it's important to sort of refer back to the evidence whenever we do our reports, really. And again, we can have it with the healing that a laceration can heal and leave a notch as sort of its only finding when you sort of when you're reviewing it later on. Okie doke, so if we move on again. So again, bumps and mounds, so these are just little, well, as described, little bumps and mounds. So rather than it being a completely smooth edge, that we're just seeing a little bump. And they're seen in newborns and in sorry, I think I was meant to say non-abused populations, and so essentially they're not a distinguishing sign. Next slide, please. Very quickly, we don't tend to do measuring widths and size of the orifices. That's something that was historically done, and the general findings are that it can't be measured accurately, and it's of not particularly useful significance really due to the general variations. However, if there is a complete or almost absence of that posterior hymenal tissue, first of all, it needs to be confirmed by moving the child into a knee chest position ideally, because sometimes you can see that tissue will sort of kind of flop into view with gravity. But you know, if that has been confirmed, then it's need to think about possible penetrative abuse having taken place. Okay, next slide, please. I think we're moving back up to Claire then. Thanks.
Thank you. I seem to have a stray end there in my slide. Apologies for that. So, what does a normal examination imply? I think this is really important for us to very sensitively manage, because really a normal examination doesn't imply anything. You know, you can have a completely normal examination. That doesn't mean the abuse didn't happen. In fact, in many examinations, in fact, probably the majority of them, or more often than not, and we will have a normal examination. Anal genital injuries heal at varying rates, and that depends on where they are, how severe the injury was in the first place, and also the location of the injury. It's a highly vascular area, and so things will start to heal very quickly. We have very limited data available. It just isn't something that people have been able to do research on. There's, you know, being able to research, you know, getting people to agree to be part of a research project when at a time when it's such a high level of trauma, you know, it's almost impossible. So really the data is on very historical things, and there is a chapter on healing injuries in the Purple Book. I have to say, I've got the Purple Book here. I don't know if you can see me, but I have to say, don't know if you probably can't see it actually. There we are, Purple Book, just so people can see what it looks like. There's a whole chapter on healing injuries so that you can refer to it from the Purple Book, but really the data is really very poor. Hymenal injuries, most importantly, often heal to leave no evidence other than in very deep lacerations. So most cases they will heal and you will have no injuries at all seen later on the hymen. They suggest that acute lacerations heal between 7 and 16 days. So actually, if you're seeing someone a month later, the chances of seeing any injury is extremely small. Again, the evidence is there in the book, but not particularly helpful because of, you know, there just haven't been studies. So a high proportion of children who've been sexually abused do not have anogenital signs at examination. This isn't just about the hymen. This is all, they haven't separated it out. So, and it also really shows how poor our evidence is. So in the studies, anal signs were found in 1 to 95% of studies, which really just shows how hopeless the research is, you know, the evidence base is. Again, genital signs in 9 to 74%. You know, it's just not helpful. What it is known is that the more common, you're more commonly going to find something after penetrative abuse, or if you examine someone very soon after the abuse occurs. However, we saw a child a couple of weeks ago in the SARC who had been raped, vaginal penetration that morning, and it was a witnessed rape, and so we had very, very clear history from the witness and from the child herself, and we examined her. It must have been about 5 hours by the time I examined her, and her examination was normal. She was postpubertal, you know, but even so, you know, and this really is so important for us to dispel these myths, because, you know, I think when we share with families that the examination was normal, we try and share that it was normal, it's reassuring, that they'll be able to move on, have a normal life in future, they'll be able to have children, you know, all of those sort of things. But actually often the family are either pleased because they think that the event didn't happen, or disappointed sometimes because they feel that this isn't going to support them in court. And I think it's really, really important that all of us as professionals, you know, whichever background we come from, that we really understand that a normal examination does not mean that the abuse did not take place. You know, basically, sorry, I just had the questions are popping up as we're going through. I just got distracted. Basically, you know, it's really, really important for all of us to be able to say to them, you know, this was normal, and that is a good thing. There are no injuries, you know, at the moment, you know, and so that's absolutely fine. But this does not mean this didn't happen, and it also doesn't mean that the case won't go to court and they won't be able to have their day, you know, in court, or their time, and they won't still go through a criminal prosecution process. And I think this is the most important thing really to be able to take through, because I think this can be something which both professionals and families really misunderstand. So basically the final point really is so important, that the absence of signs does not mean that the abuse did not take place. And something that we will always put, which is actually in the Purple Book as well, if we have a normal examination, then the final thing we'll put in our reports is this does not negate or refute the allegation that was made. So it means that it doesn't support the allegation, because you can't say there was an injury because of what's happened, but also doesn't mean that it didn't happen. Thank you.
So yes, that's just the take-home points, as Claire has already said. So just to highlight, hymenal changes, appearances change over time. Penetrative assaults can occur and leave no injury. Best to examine early when we're able to do so. Real importance of using consistent terminology, and just remembering again that the clinical examination is a very small jigsaw piece. So we've been talking here about, you know, findings with respect to what we can see in observation. Obviously, there's also the trying to take forensic samples with respect to DNA or semen presence, and, you know, most importantly, the voice of the child in these cases is the most important thing. So thank you very much.
Thank you both. That was a really useful anatomy session for me. I think I've learned a lot from your talk. Thank you. We've got a couple of questions that have popped up. I think we had a statement from Maya saying that I suppose also steeped in the myth that a woman's worth is linked to a hymen, which links to the wider causes of sexual violence generally, and I can see, you know, there's a lot of agreement around that. And then a further question, if there was a witness and survivor testimony, is there a need to do an FME? I was always taught that we wouldn't put survivors through an FME if there is other evidence that has such gravity, especially if an FME is then done and took 5 hours to, oh, sorry, it's popping up and down, to look normal. And I can see that Claire's been responding, and there's a chat going.
I mean, it's obviously we can't go into the detail about particular cases, but the it's also, we're talking here about findings, as in visual findings. Obviously, also looking for the potential of DNA evidence, which would help with criminal prosecution.
And also, I suppose the other thing to say is that the reason why we do examinations with an FME, a forensic medical examination, and also us as a paediatrician, is it's a holistic examination for children. So it's not only to find evidence for the court, so obviously as DNA, as Katrin said, but also we'll be thinking about sexually transmitted infections, taking the baseline, we'll be thinking about hepatitis, HIV, giving them medication if necessary for that. So it's much more than just the examination to prove it happened or didn't. It's a holistic, I suppose we were just looking at that section today. It's a very holistic, and also thinking about post abuse counselling and all those sort of things. So it's a holistic examination.
Thank you. Thank you very much both, and thank you for answering the questions as well. We're going to move on now. So Yasmin has been able to join us to give a quick overview and talk. Sorry, thank you, Yasmin, for joining us. I'll pass it over to you then, just to do an introduction and a bit of an overview of the events. Thank you.
Thank you very much, and Borundar. I know my Welsh hasn't improved significantly while I've been the National Advisor for Violence Against Women, Domestic Abuse and Sexual Violence in Wales, but I do try. I'm really pleased to be here this morning. Apologies for not opening the event, but it's such an important issue in all communities. But what I'd really like to talk about is what the Welsh Government are focusing on, and the diversity and the complexity of the issues across the whole of Wales. And I also want to give a little bit of insight to some changing guidance which will be coming to Welsh strategic partners who are supporting victims who've experienced sexual abuse. Firstly, I'd like to say that this issue is something that has seen an increased sexual abuse in Wales, has seen an increase, and because of the pandemic, there's been real challenges and barriers in accessing help. So what we need to do is make sure that we can provide services that are responsive and meet the needs of all communities. And when I started to work in this role, one of the first places I visited was North Wales. And I spoke to a victim who told me how difficult it was to get into the service in North Wales, because there was a bus, and then when you got into a bus, people saw where you were going, and the real challenges that affect women, accessing the help. And again, within the pandemic, there was a real waiting list for services around counselling, but I know that there's been great strides, and the government have made extra funding available to support those waiting lists being reduced. But we need a national conversation, and this is what this event is about, making sure that we understand the challenges and barriers victims of sexual abuse face, and what we need to do as services, as I mentioned before, to be more responsive. And we need to recognise the stats that tell us 1 in 3 women have experienced some sexual abuse in their lifetime, but the sexual harassment and the real issue around sexual abuse is something that we really need much more public information on, and about access to services. Of course, forensic examinations are part of the process to aid successful prosecutions, and they are very traumatic, again, for victims who need to go through the process, but it's about information and making them aware of what that process might look like. And when we talk about what that process might look like, we talk about the ISVAs, the Independent Sexual Violence Advocates, who, with my understanding, is something that is a really valued role, but there simply aren't enough of them. They simply aren't reaching out to the women who need that support to take them through that process. which forensic examination is part of, but making them understand. So if I can for 1 minute ask you to think about how that process might seem to somebody who has disabilities, to an older person, an older woman, or to someone who doesn't speak the language. And for many growing up, sex was a complete taboo. And the only person that that experience was with was the abuser. And to be put in that situation again, it's really about making sure that whatever services we're providing, that they're trauma informed, and that we can give as much information as much as possible. Because very often when victims make the disclosure of sexual abuse, that's when their risk is heightened. So when we're going through the process of, providing them emergency support, looking at whether it's a recent or historic, what support can be provided to them, and what can lead to a successful prosecution. And again, referring back to a piece of research that was done about 7 years ago now, which looked at what better outcomes for victims were, and not always was a court process or court prosecution the success indicator. It was just the abuse to be stopped. And we're all on the same page here. That's what we want. We want women to be supported, empowered, and to make those decisions. But we also want, don't we, offenders to be held to account. Because very often, if a person has been offended, it may not be, and usually isn't, that first incident. So we need to look at holding perpetrators to account. And Wells have done an awful lot of work with the secondment of Keris Miles from probation to look at what those standards are and what works well through a rapid evidence review. What we also need to do is make sure that we understand the diversity and the complexity of those survivors.
I think that we've lost Yasmin. We'll see if we can get her back online shortly. If you just bear with us for 2 minutes, please. Yep. There you go.
I seem to have been cut off. So, we're looking at the diversity of the needs of ISVAs, independent sexual violence advocates, and there are very few and far between for those in protected characteristics. We really need to understand where the need is and how we can respond better. I've been working with the Department for Education's virginity testing and Hymen plastering group, expert group, and I am in the right direction of the decision that was taken, that would be criminalized too. So there's going to be an awful lot of guidance issued to Welsh to accommodate the Welsh landscape, and that's something that survivors have really been integral to. So there's going to be additional information around, what's the mandatory guidance, what happens when someone comes to medical services around virginity testing and working with those communities at risk. And there's a huge piece of work going on with the Home Office at the moment, which will have an impact on Wales. If we haven't received some introductory information, please do let me know, and I can send that and disseminate with this partnership, because that's also something that perhaps hasn't been considered in the offer, if you like, of services to victims of diverse groups. And it takes me back to a victim that I supported who'd experienced FGM as a child, and she wanted to go into a local doctor's surgery in Wales, and she needed to see if the procedure could be reversed. And actually, as part of that examination, when she had to wait in the waiting room, I was sat with her, and her legs started to shake. And then when we went into the consultation room, there was a slight delay in the examination from the initial assessment. So that again made her very, very nervous. And when she was asked to lay down on the examination couch, she started to sweat, because for her, the experiences of what she'd, what she'd gone through that cutting, she started to explain it to me, even though I'd heard it again. And that real trauma, that post-traumatic stress disorder that she experienced, for me to be in that room and to listen to her and to hear about the impact it's had on her life, and for her to be transported back at that time when she was being cut, really brought it home to me. So that's also something that we should be considering in terms of, looking at it from a trauma-informed lens, looking at the examination through, because it's very cold, as you would expect it to be, but making sure that we understand through the risk assessments that we've undertaken to get the victim to the stage that she's at through the examination, really having that understanding puts that victim at ease, puts the individual at ease. It makes them understand that you are understanding and you're empathetic, and you understand how difficult this is for them. So I think from a diversity perspective, I think there's a lot more we can do, because the risk journey needs to be understood better. And I think through those pre-screening documents that we use, or for forensic examiners use, the training that we're currently receiving for staff who are in those sexual assault referral centres, making sure that we understand the complexities, which I really do believe is going in the right direction with the national training framework. We've just refreshed the national strategy, which is due out imminently, and there's specific reference to that. But it's making sure that we're joined up in Wales, that regional boards and national policy can inform better outcomes for individuals, irrespective of who they are and where they live. We know that in Cardiff and Swansea that there are a robust network of services. We know that there are some additional challenges in North Wales, but making sure that we have that guidance, which is very robust and it's overarching and it considers the diversity of victims and the aim to have a successful prosecution with the processes in place that can assist in the best way possible. I think the Welsh Government have been very ambitious, and although we haven't got things quite right, and it's impossible to do that, this is something that is very, very high on the agenda. I think you can see that with some of the position statements that have been delivered by the Minister for this portfolio, and certainly this work will continue going forward. I think it's really wonderful in Wales that we are shining a light on sexual abuse and the services that are available. I think the agenda has been really well framed to look at the complexities, but I really want us to continue working and driving forward those changes that we need in Wales to ensure, irrespective of who or where you live, you can access services and that you are understood and those services are fit for purpose. I'm more than happy to stay in for another 5 to 10 minutes. If anybody has any questions, I'll be more than happy to stay on.
Fab, thank you, Yasmin. We really appreciate you joining us today and highlighting the importance of this work and what Welsh Government and yourself are doing to take to drive this agenda forward and ensure that sexual assault services are priority and provide the care and support that victims need going forward. There has been some discussions in the chat bar, but if there are any questions for Yasmin, if anybody would like to put their hand up and come in, please do. If not, then no, I don't think we've got any. No, then thank you. I just to thank you again, Yasmin, for joining us today and everything that you've been doing as a national advisor, taking this this agenda forward for not just for sexual assault, but also for the whole WSAS agenda. So thank you.
Thank you.
Okay, thank you all. So we will move over to our next presentation, next presenter now, which is Dr. Claire Lepetz, who's going to be giving a presentation today on sexual assault and the care of the victim. So over to you, Claire. Thank you.
Thank you very much, Jo. I'm going to talk about my work looking at people who require a forensic examination, and that's all ages and genders. I'm not including visuals here, but I was pleased that the slide that Catherine and Claire used is very relevant to some of the terminology. I'm originally professionally an obstetrician and gynaecologist, and I specialised in sexual and reproductive health. The only reason why I illustrate this background is because forensic medical examiners come from a real variety of backgrounds. Claire referred to somebody who had worked in gynaecology, and there are doctors who have been GPs before. Until relatively recently, there have been no forensic qualifications, and in the last decade there's been a lot of work looking at forensic standards, forensic competencies and forensic qualifications that we can now base training on, which is really important, because a lot of the things that Catherine, Claire and also some comments in the chat have alluded to is all around competencies to do this work, which is complex. I also work in the Gender Urinary Medicine Clinic as a sexual and reproductive health consultant, and I do psychosexual medicine as well. And the impact on people's lives in terms of their sexual functioning is absolutely huge in this work. And I think experience of examining people is really essential in a non-forensic context to make this work really as sensitive as possible and as victim focused as possible. So if we go on to the next slide, when we actually meet someone, and I use the term complainant at some point as well as victim, and there's different language around the person who presents having been a victim of sexual assault. But the needs that we need to think about are often around their safety, and they need to feel that they are safe. They may need acute medical care. Often that initial assessment is actually being done by first responder police officers, and also to have immediate reassurance that they are being taken seriously and they will be going to a safe place. It's quite common to have non-genital injuries noted, but they may be minor and not require attention in A&E. We like to do the forensic examination soon, and then there are other offers of practical help as well as medical issues such as emergency contraception. And then we have to think about the future needs, and that initial assessment is really important so that we know what we should advise, whether that's in 2 weeks' time or 4 weeks' time or whatever the time frames are. So we'll briefly touch on that. I think one of the things that we have to take on board is that any intimate examination can effectively have the potential to re-traumatise somebody, particularly when you're effectively looking at somebody as forensic evidence and as a crime scene, and they are actually a human being who's just been through a traumatic event. Next slide, please. It's already been alluded to in the chat, the huge scale of sexual violence, and this is quite an old slide, but I just like the fact that you see it in a pyramid, that there is a huge number of offences that are not reported. There are some that are reported, and then there's a proportion that are counted as recorded crimes, and then become detections. So the numbers really don't do justice to the huge number of people who face sexual violence every day, every year in the UK and worldwide. Next slide, please. Having this awareness, I think one of these researchers is Jess Taylor's been referred to in the chat already, but this is quite a useful infographic to show those data, and also the realization for some people that something that they have taken as normal is actually not normal, and it is sexual violence. And I've seen that particularly as lockdown had its effect on older people who were in abusive and coercive relationships, an increase in presentation there, and they realised that a lot of the violence that they'd experienced was actually they were able to label as violence. So these are really sobering statistics. And if we just move on, please. So this is a little bit about FMEs. Although the forensic medical examination is requested as part of the investigation, they're essentially providing third-party evidence, and there are some important legal distinctions around that evidence. It should be a therapeutic medical when the examination happens, with a risk assessment, which can include mental health needs as well, and sometimes some immediate treatments. And all of the skills that FMEs need are really around holistic care, as well as doing a very clear and targeted examination. And there are a number of organisational issues that we're addressing as a nation in terms of funding, services, resources needed for training, type of documentation we use, all sorts of things. But the forensic medical examiners are a fairly broad group from a number of specialties. Next slide, please. There's a reference to how soon we do an examination. So an assessment needs to consider what we call the forensic window. So how soon evidence is lost is an important consideration. And prepubertal examination needs to be done more rapidly as the forensic window is shorter. There's lots of guidance around this, and it's I'd refer you to the Faculty of Forensic and Legal Medicine for that, because it's updated twice a year, and is very clear around where evidence has changed and evidence-based decision making on the samples that need to be taken. It's also really important because although you consider a top-to-toe examination, you do not want to put somebody through a particularly lengthy and very long examination if that's not required. The other issue, though, is that we're not always collecting forensic evidence and DNA. I think lots of people have watched the SI series. That's not what it's all about very often, and sometimes any forensic evidence that's obtained won't be of any particular use, because the perpetrator will say that, yes, I was there, I did do that, but it was with consent. But there are a number of other signs and a number of other findings on examination that can support what the victim is saying. So that might be to do with bruising, might be to do with injury, and very often in the discussion in the forensic examination, additional information is obtained and given to the doctor to direct the examination. Next slide, please. So this is just an example, and it talks about why you would do the vulval swabs. It's also very clear in terms of the terminology about what is outside on the vulva and what is inside within the vagina and the different vaginal specimens. It's really important when taking a history to be aware of the victim's use of language, and I'm sure that the vagina monologues and American terminology have got a lot to answer for, because very often women will refer to their external genitalia as the vagina, when that's actually the wrong terminology. So finding out the words that the person uses about themselves and how they label themselves is really important to try and work out what's actually happened. There are certain techniques about taking the swabs, and there are instructions around that are provided in the FFLM guidance. Next slide, please. The early evidence kits that are often used, that are before the medical, are often done by either crisis workers or the police, and that's very helpful to do an initial collection. And if the person isn't sure that they're going to proceed to a forensic examination, if they want to think about it, and particularly if they want to drink, if they want to have something to eat, it's very good to do the oral module. One of the reasons for doing the early evidence kit is to obtain evidence without having to take a history and re-traumatise somebody or keep asking them questions that are inappropriate. So if this can be volunteered by the victim, it can be very helpful when other aspects of an assault may come to light. So that's often done prior to the examination. The other reason with the urine module is for screening for drugs and alcohol, and if you take a urine sample later on, you have 2 time points where you can compare in the lab the levels of any substances in the urine. Next slide, please. It's also possible to for the person to take swabs themselves. This is very common in general healthcare, whether it's sexually transmitted infection swabs that are done at home, whether it's screening. People are used to being asked to do something to themselves. This can also be extended to the forensic examination if necessary, as part of an early evidence kit. And there are requirements where the victim has to double glove, and those gloves are exhibited. The importance of this is, although it's something that can be done and is sometimes important to do, it's not intended to be an alternative to the forensic examination itself. Next slide, please. I think a really important part of the preparation for the forensic examination is the consent, and the crisis workers that we work with within the SARCs are really well versed in explaining what the forensic examination entails, who's going to attend. I think we always imagine things to be worse than they actually are with medical procedures. And so it's important to explain to people what to expect. There isn't an army of doctors in white coats coming. With COVID, obviously, PPE is worn, so that's very similar to how things would be in hospital. But some people haven't been examined at all, haven't been in any kind of healthcare setting, and so that's an important part of explaining what the examination entails. Next slide, please. Within the examination, there is sometimes a request for a female examiner, and there is some evidence that men and women who are victims prefer to be examined by a female doctor. It's important to understand that an FME is not the same kind of doctor you would see in any other setting, and the reason for that is the elements of disclosure around the examination. It's not confidential in the same way it would be if you went to see your GP. In terms of taking the story of what has happened, it's important to establish that because of the samples that need to be taken. You wouldn't, for example, want to take genital samples where actually the alleged assault doesn't involve genital touching or penetration. That would be totally inappropriate. We also need to know a lot of medical details, a gynecological history and social details, and there are lots of reasons for that. For example, whether someone is menopausal, whether they're on any medication that might make them bleed more easily, whether they've had a recent surgery, all sorts of things. Their social history, I'm referring to their housing, who they live with, what support they have, and also a mental health history as well. If they're going to miss any medication that's time sensitive, then we need to know that so that we don't delay their normal medication. We often use a body map and a chart, so they're often visible to the person, and I usually warn people that I will be taking notes, and I find that those diagrams are very depersonalizing. They're intended to represent a map for us, not that particular person, but I'm always concerned that the person may feel that they are being depersonalized and not really focused on because of the accessories that we need and the things that they will see as part of their examination. And we consider emergency contraception, STI screening, and further onward referral for support. And at the end of it all, we'll probably have to write a statement for the police. And very often our statement will come to the conclusion that we can't tell whether something happened or it didn't happen, and that the findings are normal. And it's important within that to explain that even though everything can appear normal, it doesn't mean that something hasn't happened. Moving on. So the FME has obviously a duty of care to their patient, but they also have a duty to the court. They're responsible for the notes and any pictures taken. And it's really important within our competencies to be very clear about our safeguarding responsibilities for children, and also the legislation around consent for sexual intercourse. Often we treat 16 and 17-year-olds as adults sometimes, which is not appropriate, and that often surprises me when I'm checking, for example, with a 17-year-old and asking who is accompanying them to the SARC. And it's quite interesting considering the support network around adolescents and young people is often very lacking. Moving on. Most commonly, the place of examination is in a SARC, but it is possible that we have to do examinations in a hospital setting, and it's really important for us to consider the facilities that are there, because people need privacy and they often want the opportunity to have a shower afterwards and have a change of clothing. Next slide. As I alluded to earlier, you don't want to have a constant rerun from previous accounts, but it's important to note that the account that the doctor is given is often very likely to be slightly different from an initial account, not least because people can remember things, but as they open up to say exactly what happened, more comes out, which actually directs the examination. In particular, usually the worst thing for that person within the assault to have happened is the last thing to be disclosed. So there's quite an important way of eliciting that information, where you absolutely need to build a rapport and an environment of trust with that person to enable them to disclose what's happened to them. And it's really important where we're assessing other medical needs. I have had someone who did have a head injury, and I hadn't been doing the examining people for very long, so I was very focused on the genital forensic examination, and actually they had a head injury and a delayed presentation, therefore to A&E. They were all right in the end, but we have to consider all of these other things. Next slide, please. So I've mentioned this. I don't think, and I query always the relevance of previous sexual assault, but when I was trained, we were always told to ask people about previous sexual assault. And in my first 100 cases, 96 of them had previously been sexually assaulted, and I considered it irrelevant information. The previous sexual assault around the same person is often very relevant, but to say it as a blanket query is not helpful, in my opinion. Next slide, please. If we're using the colposcope, which is helping us to visualize the genitals, then we need to get the person in the right position for examination, and then maybe other photography that would be taken afterwards. It's really important, if there are extragenital injuries, so anywhere else on the body, that they should be photographed by CSI photographers who have the equipment, they have the light balance, and they take much better photographs. And I think that's really important, in particular where you're looking at darker skin, where bruising might be quite subtle, and the photography can be really important there to be done properly as for the police evidence. But the colposcope is used. The position for the examination is usually frog legs. We try and avoid stirrups, and recognise that the person has to be completely comfortable to allow the examination to happen. And many of our drawings are on these template body maps that we use. Next slide, please. One of the things that's particularly difficult is when someone's asked to wear a gown. It's very exposing, so we tend to go for minimal exposure at one time. People feel very naked and vulnerable, and there's the it's very important to communicate throughout so that the person knows what we're doing. And it's very important to be attuned to people who've suffered trauma and may well dissociate during an examination, and to pay particular attention not to just what we're looking at, but the whole person. Next slide, please. I won't revise all of the anatomy. Suffice to say that we need to be very sure of what we're looking at and the terminology, and relate that to what the person uses about their own anatomy. The reason why it's very important to get all of that right is so that you can be clear where the specimens are from, and if the forensic evidence is ever used, it makes a difference to the charge as to where that evidence is obtained from. And I just refer you back to that initial drawing that was used in the first presentation. Next slide, please. So we think about the other needs, in particular emergency contraception, and we have to do that and take into account episodes of consensual sexual intercourse where the person may actually have no objection to potential pregnancy at another time in their cycle, but actually they absolutely wouldn't want to have a conception from the sexual assault. Sometimes that's from the same person within a relationship as well, which is complicated. And we need to be able to give the person their assessment of risk if they need emergency contraception, and then an assessment of whether that contraception will work given the time of their cycle. The other thing is, if a pregnancy results after a sexual assault, that is obviously a source of DNA from the perpetrator, and that's particularly important to follow up if it's likely that there is a risk of pregnancy. Next slide, please. So the sexual health screen is important, and where it happens and when is important, and the assessment is quite difficult because there are different timeframes for different STIs, and somebody of course may test positive if you do a baseline screen because they may already have chlamydia, for example, as a common STI. So actually the time scales are often important, and we sometimes offer treatment for STIs where it's not proven, and The reason we would do that is if the victim is likely to be sexually active, again with a consenting with consent with a partner, and that does happen where women have been sexually assaulted by someone. They don't want to share that with their normal sex partner, and they are sure that they could not delay, and they don't want to delay having sex with their normal consenting sex partner. So it's really important to be having those conversations with people and allowing them to describe what they need and what we can do to help them. Post-exposure prophylaxis and HIV risk has changed dramatically in its assessment since the advent of antiretrovirals for people who take it as pre-exposure prophylaxis, and for people with HIV who actually are on early antiretrovirals. So the risk calculations that are used are old, but obviously that's something that people often are very concerned about and needs to be discussed. Next slide, please. In writing our statement, we can have very long statements documenting every abrasion, graze, bruise, and they are all important positive findings. And we always have to remember that we are a witness of the examination of the person in front of us and not the act that happened. Very often, I think a huge responsibility is put on the forensic medical examiner, and a huge weight is put on the forensic medical examination, which shouldn't be there. So it's important to outline interpretation of findings, particularly where it's limited, and the fact that an absence of genital injury doesn't mean that something didn't happen. I think what's very important within the examination is to always model respectful behaviour as part of the attitude towards holding someone who is going through this experience, and really being very clear that at every stage of the examination we are being given permission to access the person, and everything is done with consent. I would say it's always better to examine than not. I've had a number of examinations where at 3 o'clock in the morning I think, this doesn't sound like anything very much, and I have learnt my lesson by attending many cases and actually finding evidence that nobody expected. The only time the back of the person's body is properly examined is by the doctor, and one can find signs anywhere on the body. So it's always better to examine than not. I think this is a complete run through and a very rapid tour, so it would be really interesting if there is a moment to answer any questions. So diolch yn fawr iawn, thank you for your attention, and that's the end of my talk.
Thanks, Claire. I think there have been a couple of questions in the chat. We've had, I'm just going through them now. So the most recent one was Evie, who's asked what support is available to children and young people who've experienced sexual abuse during court proceedings and after court, especially when there are such low conviction rates, especially with children, especially children who are looked after. Who would I contact to get them support?
I think one of the things that is really important with young people, and maybe illustrates my last point about it being important to do the examination, are things that don't come across if a case does go to court. So I had one example where I was not expecting to be called as a witness, because sometimes the medical evidence is never used, even if it's there. And it was a young person, and it was a historic one. So the forensic medical examination had been requested because this person had requested it. So in fact, I wasn't collecting forensic samples, but they were very sure that they had somehow been damaged. So it was a very healing examination for them because they were reassured that they had normal anatomy. However, they were very small, short stature person, and I had their growth charts, and they had stopped growing at a very young age. When they went to court, they didn't appear in court, they were on a screen. And no one had really appreciated the size of this person, and they were in fact, if you saw them at a distance, if you were walking behind them in the supermarket, you would assume that they were you know, a 10-year-old child. And that was a very, very significant piece of evidence that hadn't been brought to the fore, and it seems very simple, but the jury hadn't seen the size of the victim compared to the size of the defendant, and it was only by being present as one of the witnesses at court that actually came out and was considered significant by the judge, who actually asked for more detail around that. So sometimes there are really small things that can be quite important. I know that asking for a photograph of somebody's knee, the dirt on somebody's knee, was actually the imprint of a manhole cover on which she'd been assaulted, and helped put a place and find out the place of the assault, which led to CCTV footage, which led to identifying a perpetrator. So sometimes it's quite odd things that we don't think would be significant that actually turn out to be. There's a question about dissociation, and I think in training it's difficult to know who has been trained exactly in that, but I think as someone who does intimate examinations on a daily basis in my non-forensic work, and having had some particular training, I think I do have that. I think a lot of the training that comes out is around consent, and making sure that doctors understand that consent can be withdrawn at any point, and always having that level of communication with someone so that you know that whatever you're doing is okay, and stopping when it's not okay. So it is quite variable about specific training. Some of the things, I think it's really important, whether it's a crisis worker or a doctor or a police officer, to be aware of what people need. Sometimes people want a conversation about something completely different, like where they had their tattoos done, or how old they were when they had their ears pierced, or you know, something that's completely outside of the examination. And some people, because they don't want to be in their body, they want to be taken away from it, while they're also saying it's okay to carry on with the examination. So we have to be attuned to what people want and what they're directing us to do. And one of the other issues is that we really need to hold that person and believe what's being presented to us. And I say believe sort of in inverted commas. I'm not there to prove or disprove something. I have a neutral status as a forensic medical examiner. However, being in an environment where the account is believed is a very important part, I think, of the whole holistic approach, and the acceptance of what somebody is saying to you, and the ability to hear it and hear the last awful bit that they may wish to disclose to you, is a very important skill, and is very supportive of the victim.
Thank you, Claire. That I found that really informative. You know, putting the victim in the centre of care, and making sure that everything that we do is focused around them to get the best outcome that we possibly can, and ensure that they are cared for and felt held right the way through the process that they have to go through. Thank you. I know that there's a few other comments in the chat bar, which if you're okay to answer them in the chat, so we can move on to our next presenter. Thanks, Claire, again. Hi all, thank you, and welcome back to the final presentation for our session this morning. I hope you've all managed to grab a quick cuppa and have a comfort break in the 15-minute break. So without any further ado, I'd like to pass us over to Dr. Deborah Hodes, who's going to be giving us a presentation on female genital mutilation and the physical signs. So over to you, Deborah. Thank you. Oh, Deborah, you're on mute.
Thank you very much for inviting me to give this talk today, and I will give you an overview really of FGM, which I hope will be helpful, and hopefully there'll be a few minutes for questions at the end. Next slide, please. So the learning objectives are about how common it is in the UK, the definition, the practice, how you and how we in London assess FGM in our children's FGM service at University College Hospital, and more importantly, your role in when you are suspecting a case of FGM or you're wanting to talk to someone about it. Next. So the definition, World Health Organization definition, is that FGM comprises all procedures involving partial or total removal of the external female genitalia or other injury to the female genital organs, whether for cultural or other non-therapeutic reasons. And if this was live, I'd be asking you in the audience, what do you think about that in relation to what's going on in the country? Can you think of any other examples where this might be happening legally? Does anyone want to say? Try and make it a bit interactive. Anyone think of any other procedure that happens to adult women in this country with their choice that fits into that definition?
Gender dysphoria type things, Deborah.
Gender dysphoria, what aspects do you think
the surgical treatments thereof, you know?
Treatment.
Interventions.
Well, I think that will be exempt from this definition. That's what you're suggesting for that part of the body. And anybody else got any other suggestion? I don't know if you read magazines, young girls magazines, but labia majora and their symmetry, asymmetry, and what they look like is a big thing now. And labiaplasty has increased by a huge percentage in women over 18 who are allowed to consent. So if you think about labiaplasty, which is trimming of the labia majora, the large lips, that is allowed in women who can consent, and that fits into the definition. That's a discussion to be had, and I think it's an important aspect of the definition. Next slide, please. So why do people carry out female genital mutilation on their daughters? There are lots of beliefs and misconceptions all over the world where it is carried out. It's a rite of passage. It's part of social obligations. People believe it's readiness for marriage and adulthood. There's a lot of fear of the clitoris in many societies and female sexuality. They believe it reduces sexual desire. Some people believe that it's aesthetically pleasing to have a smooth vaginal area, external genitalia, and it purifies the body. Many believe it's a religious requirement, but it is not written in any religious scripture that it should be done. And in fact, the Prophet Muhammad really talked against it, and none of his children, or none of his daughters were circumcised. And also it believes that people believe it protects against material wants. Next slide. So what influences the practice? And this is very important because obviously, apart from prosecution, which is quite a big thing in the UK, we have to think about preventing it, helping people understand why it isn't a good thing to do. And in fact, it's extremely harmful and abusive thing to do on daughters. But the protective factors are when a mother is able to discuss with a husband, a friend, and understand the implications of having this carried out on their daughters. Knowing the law, and the law has actually been implemented, and as you might know, there's only been one case prosecuted successfully to date. That was in the UK, in England, in the last few years. The TV, media, and global debate is really at the forefront, and people know that it's out there to be discussed. Men's attitude and knowledge, which is actually interesting. Knowledge is very low. They think it's a woman's business. They don't really understand what's going on. And in some of the studies where they have found out and it's been explained to them, many are really horrified and don't think it should take place at all. Knowing an uncut person is important. So knowing that that person is okay, they're quite normal, they're not wild, they're not bad, nothing awful has happened to them. But from the risk point of view, when there's a family history of someone who's been cut, mother, sister, other relatives, the mother's isolated, very important, the influence of the grandmother, particularly when families go abroad, which is what a lot of the publicity has been about, going on summer holidays. Little information, discussion, and the communities have the impression it's not taken seriously. But I think by now in this country, they do have the impression, and so they're very fearful of what might happen. Next slide, please. So I won't go through the normal genitalia next, but I'm going to tell you about the types of FGM, because as you know, the definition is very broad and there are different types that are carried out. Often relates to the country, and we know now over the last 50 years, it has, what has actually done has changed, and that the what you know of as FGM, where women are cut and sewn closed, which I'll go on to show you, is only in 10%. That is millions of women, but as a percentage, it's gone right down compared with 50 years ago. Type 1, as defined by the WHO, is when the tissue around the clitoris is removed, some of it or all of it. Type 2 is when more tissue, more flesh is removed, as defined by UNICEF. And this is not only around the clitoris, but also the small lips, the labium minora. And this, again, can be total or partial. And sometimes in type 2, there is a little bit of stitching because there has been some bleeding and a scar tissue is seen. Next slide. But in type 3 that I just talked about, in around 10%, the woman is sewn closed. And you can see there's a tiny vaginal orifice, which leads to lots of problems of passing urine, menstruation, sexual intercourse, delivery, etc. Next slide, please. And here you can see type 4, which is increasingly common. It's what's carried out in all Southeast Asia. It often leaves no physical signs at all. So you can see by the clitoral hood, that red line, which represents either a prick or a cut, which may leave a scar around the clitoris, often usually to one side or another, but sometimes over the clitoris itself. And with a colposcope, with, in other words, with lighter magnification, it's possible to see the scar tissue. But if there's just been a prick, then nothing is seen. And as I said, in the last 5 years, it's been realized that 50% of children in Indonesia and Malaysia, young girls, are what they call circumcised in the first year of life. But in most of them, there won't be anything to be seen. And this is also what happens in the Boro community, which you might have read about because there's been quite a lot of publicity and cases in America. And they also carry out what is known as type 4. And then you might debate, is this mutilation? Because is there a change in the physical anatomy of the girl and the woman? So again, that's another debate that we might have at the end. Next slide, please. So the consequences, I'm not going to go through all this for time, and also the non-medical people in the audience, it's probably not so interesting. But there are acute consequences. In other words, when a child is cut, they will be in varying amounts of pain, and they can bleed, and a lot of bleeding, hemorrhage might sadly cause death in girls, and the figures are not actually known. But the two acute cases in Republic of Ireland and in this country that I've been involved with, the young girl, both under 5, presented to A&E with bleeding, unexplained bleeding from the genitalia, acute bleeding, and a lot of bleeding. And this is a complication of genital mutilation. But it doesn't occur very commonly in this country, as you can see here, because there's only been two cases where the cause was found to be mutilation or cutting, as it's often caused, female genital cutting. Next slide, please. And there are long-term consequences, which are gynecological, obstetric, and psychological, as you can imagine. Many women suffer from post-traumatic stress. Many have difficulties with pregnancy, with sexual intercourse and delivery. And in many countries of the world, having delivered, the baby, the woman is sewn up again, ready for the next pregnancy. And in some communities, what women say, which is really traumatic, is there are 3 bad things in a girl's life. One is when they're cut, when they're a child, and the ages vary. The second is when they get married on their wedding night, because either they need to be opened before or sexual intercourse is very traumatic and painful. And the third is when they have their first baby. Next slide, please. And this is just listing the obstetric consequences and the psychological consequences. Next slide, please. So what sort of approach can we take to this? Because one might say it's a cultural practice, and this should be allowed and left to the communities to decide, independently of the complications that I've just described. But I think it's very important to take a rights-based approach. And if you think about the United Nations Convention on the Rights of the Child, 1989, which most countries have accepted, Article 24, appropriate measures to abolishing traditional practices prejudicial to the health of children, and FGM would certainly fit into that. Article 19, to protect the child from all forms of physical or mental violence, injury or abuse, neglect or negligent treatment, maltreatment or exploitation. And obviously FGM, thinking about the definition and the consequences, does also fall into that. Next slide, please. The law is important, and I think it's important for you to know the changes. Despite FGM being known about, or cutting of the genitalia in some form, for many years, long before 1985, the first law wasn't passed till then, and it was the Female Circumcision Prohibition Act. Then it was realised that children were being taken abroad to be cut. So in 2003, a further act said that children were not allowed to be taken abroad to be cut. Then one of the defences and there are few defences to this action, would be that the parent will say, well, I'm not responsible for doing it. We went abroad and someone else organised for the cutting to take place. I left my child with the grandparents for a weekend, and so I'm not responsible, and therefore the parent could not be prosecuted. But this was changed in the 2015 Serious Crime Act, that the parent was responsible for protecting their daughter from being cut under any circumstances. And the other thing, which I'm sure you're all aware of, is mandatory reporting to the police of under 18s with FGM when it's seen or suspected. Next slide, please. So this is the mandatory reporting process map, which I found for Wales, which I hope you're all familiar with. And I'm not going to go through it, but you can see at the top, there are 2 main pathways, which I can't point to, as you know, one on the left side and one on the right. On the left, mandatory reporting must be done to the police if a child says that, or young girl under 18 says they've been cut, or if you see physical signs. On the other side, when you need to report as any safeguarding concern that you might have, and you report to local authority, is when the child or the young person has already been cut, and they perhaps come newly into the country and they have had a history of FGM, or you think that the young girl or the child may be at risk of being cut. So when, for example, and we know commonly all pregnant women are asked, and a woman has been cut, you need to know or be assured or reassured by that mother that she has absolutely no intention of having her daughter cut, nor going abroad to have it done. And in that case, that's fine. But if you have a suspicion, again, you need to report. And then carry on going down the flow chart to see the further actions, which I won't go through. But it is important that you're familiar with this. Next slide. How common is it? And you'd think from reading the papers that every second person from a practicing community was cut, and every daughter was absolutely at risk and was going to have genital mutilation either in this country or be taken abroad. But we, in the two studies that I've been involved with, are not convinced of this at all. And I think we're at loggerheads with the police, who do think that it's happening a lot and it's hidden. I would say if it's happening a lot, we would see more presentations. But of course, this is to be seen as time goes on. Next slide, please. So one study which Welsh colleagues, Welsh paediatricians, took part in is the British Paediatric Surveillance Unit study. And this study is something that paediatricians do, and they ask colleagues, all consultants all over the UK, to fill in this form, as you can see on the left, the orange form, when they see a rare condition. And we managed to have female genital mutilation on that list of rare conditions for 2 years. And people reported if they saw a case in this time period. And if you'd like to read the details, you can see the publication there, but I'll just tell you some of the findings. Next slide, please. What was very important in the 2 years of the study period, and we're talking about girls and young women who present to paediatricians. So of course, the police would say most of them are hidden and they haven't turned up, and they haven't told you that they've been cut when you've asked. But even so, given the publicity from the newspapers, I would still expect quite a lot, thousands. But actually, in the whole of the 2 years, there were only 103 confirmed cases that presented to paediatricians. And the mean age that the FGM was carried out was 3, so quite young. So under the age of 5 years in over 50%. Next slide, please. So our findings from this study, the British Paediatric Surveillance Unit study, and also the findings from our clinic study looking at the cohort of children who came to the clinic, are actually very similar. You can see here that 25% were carried out by what was known as a health professional. In other words, not a traditional circumciser, which is still high, 20%, but not as high as I think people would think. So maybe it was done in a health centre, done by a nurse, by a midwife, even a doctor. In Egypt, many doctors carried it out until very, very recently. And it was thought to be something that was essential, that in Egypt, mostly it was the clitoris being removed in the first few months of life. But as I said, in different countries, different practices and different percentages. Next slide, please. And what we also know, and we've been told, is that children will present at school, in the nursery, in the community, with various symptoms. But in the study of 103 girls who presented, only 22 had some sort of symptoms. And although it was thought to be due to the FGM, many of these symptoms are incredibly common in girls anyway. And so it's very difficult to attribute it to the history of being cut. And the reason why it's 22 as well is because some of the children had more than one symptom. So what it's saying to us is it's not a terribly good pointer to suspecting FGM has been carried out. Next. Criminal investigations in this cohort of 103 were again really small numbers, and you can see that although 9 there were criminal investigations started, at follow-up, because we followed these children up for 6 months and asked what was happening, only 3 was a continuing criminal investigation. 4 were not known what was happening, 2 weren't known, and 4 cases were dropped. And out of these 3, there was only 1 successful prosecution for FGM, and the 2 remaining cases were under investigation as part of a wider investigation of child cruelty. Next slide, please. So in conclusion, there's a very low % of type 3, as you remember, where girls are sewn closed, which was 10% and consistent with the worldwide data. Low numbers with just type 4 with just a prick, which actually is different to what we found in our clinic study, which I'll tell you about later. There was evidence of medicalization, in other words, it was carried out in a medical centre. And the physical and mental health symptoms were much less than we have been taught and would expect. Next slide, please. So next slide. So what's your role here? So this, before I go on to some other aspects of my work with FGM and the clinic we've been running in London for well over 5 years, is what is your role? And I think what's very important is that you feel confident to ask women and girls, have they been cut? We do ask all pregnant women, and in most places everybody is asked in a tick box question wherever they're from. So for many people that seems an absolutely crazy question, but it's easy and less stigmatizing for some people, and midwives may feel this, and in some hospitals that is the directive. So anybody who has been cut, you have to be mindful of what they think about it and what they're going to think about if they have a daughter. But in other situations, maybe your health visitor wants to check, perhaps it wasn't asked by the midwife, perhaps they still want to ask the question themselves. For paediatricians sitting in a clinic, you need to know, when you're taking a family history, does the family come from a practicing community? Do you come from a community that practices cutting? And I think in the family history, actually, whether it's in the red book where the risk for the baby is written about, in the red book, there is a little place for risk for the child. So for example, if there's a family history of epilepsy or haemophilia, that will be written in, and I don't see why we shouldn't include FGM, although some people would debate that and be against it. But the main issue is to ask the mother, ask in the family history whether that they come from a practicing community. Because many people, even if they come from Nigeria, for example, where it's practiced in something like 30 or 40%, it depends where they come from, which part of the country, because it might be something that isn't practiced at all, and it's best that you ask. And most people don't mind at all. And then the next question, of course, is to ask the parent, the mother, have they been cut, and what do they feel about it, and what do they think about their daughters, to ensure that they understand the law, to find out what their attitude is, and to consider whether you need to refer on to social care because of the risk of being cut, or whether in fact the girl has been cut because she just came from a practicing community, she just entered the country, and there's a history of FGM. And then you need to think, does she need any post FGM care? What was the extent of the cutting, and has she got any symptoms from that now to keep her healthy? And we had some girls in the clinic, not now, because the teacher would have been duty bound to report them, but there were 16-year-old girls, 2 sisters, who heard about FGM in the clinic, in the school education. they went up and said that they'd been cut before they came to England, and they wanted to know what had happened and what their anatomy was like and were they healthy. And those 2 girls were referred to our clinic. We examined them, we explained their anatomy, and they were extremely pleased to feel knowledgeable about what had happened. But of course, now it's a bit harder, because then you're duty bound to report to the police, and there can be an investigation, which is very traumatic, even if it's not illegal. The investigation can take place and not go well. Next slide, please. So when the paediatrician sees the child, and when there is a referral because of a suspicion, or someone's made a disclosure that they were cut, the diagnosis is important, taking a family history, examining the young person or the girl, thinking about the consequences, both physical and psychological, considering future pregnancies and any siblings, cousins, any other girls in the family who may be at risk or may have been cut legally or illegally. Multi-agency collaboration, everybody needs to contribute, and prevention, I think, is the key, really. And so in all places that you work, it's important to have a poster so that people know it's illegal. Someone who's just come into the country might not even know that. Know where to get help from if they have been cut, and know that it's okay to say, and that they won't be stigmatized. And that obviously we want to prevent it happening to any future girls. So I think that education is absolutely important. And many communities, as we know from the work in Bristol, know very well about cutting, that it's illegal and that there's no benefit to the child. So it's important not to make assumptions. Next slide, please. I'm going to talk about the Children's FGM service at the University College Hospital, London, which we opened in 2014 because there were some children being seen referred because of abuse or referred because of suspicion. And so we decided to open a specific clinic. And a year later, the 2015 Act came into power with mandatory reporting. And we actually thought we would have to change the monthly clinic to weekly. But actually, you'll see from the statistics that we didn't get the number of referrals we expected. Next slide, please. So just to tell you what happens in the clinic, and I don't think this would be very different to a child who's seen in your SARC with a suspicion or an allegation of sexual abuse. They will meet with someone to play with them, to introduce them to the clinic, while perhaps we, the paediatricians, and we run the clinic with a gynecologist, a psychotherapist, and a clinical nurse specialist, will have a discussion with the police or social worker. Of course, now it's a phone call because of post-COVID. Next slide, please. We would then take a history and the child is introduced to the examination, what happens, and the examination couch. As you can see, with what in the SARC might be a crisis worker, we have a place specialist where we're working in the clinic. Next slide, please. Important to take a history of the ethnicity and religion, and we've had, as you'll see later from our clinic study, that some people's come from an ethnic group are referred to the clinic, and they come from a group where FGM is not practiced. You might ask why they were referred, but these things happen, as you well know, and it's important to check out with the parents, what is their ethnicity? Do they come from a practicing community? We've had people from Pakistan where it isn't, I mean, you can never say never, of course, but generally speaking, it's not carried out. We've had people from religions where it's not carried out, even though it's not a religious practice. It's important to know what their religious belief is. Rural, urban upbringing, an educational level, we know from the studies that it's less likely to practice in an urban upbringing in other countries in the world, and with high educational levels. Many have had it before they come into this country where it was not illegal, so therefore the mandatory reporting route, as you remember from that flow chart, won't need to be followed in exactly the same way, because there's no possible illegal practice here and possibility of criminality. And as I said before, family history and attitudes to FGM are all important. Next slide, please. So we need to know the age. Do they remember? Was there a social occasional ceremony? Because we know in some country, like Sierra Leone, there's a ceremony, there's a ritual called Bondi, where the girls are taken into a secret place. They're taught about marriage, about the work of the wife, but very, very traumatically, they undergo genital mutilation, which is incredibly traumatic to the girls, before they're then sent home. Was it done alone or in a group? We have to think about risk of bloodborne viruses, and everybody we see in the clinic is tested if it has been done abroad and we're not sure about the circumstances of it being done and the risk of bloodborne viruses. Next slide, please. What were their parents thinking? The cutter, type of cut, and how it was happened and what happened afterwards. Many children, I mean, the classic thing that people know about is the children are restrained, and from that they can get fractures and injuries from being restrained, and then afterwards difficulties with infection and other complications, as I said earlier. But other children, it's done in a health centre, even done in a hospital with local anaesthetic, with painkillers and antibiotics, and really very, very few untoward consequences. Next slide, please. Asking about the history, about the symptoms, which we did find occurred, but again, we don't know how much they relate to the FGM, but it's important to know, and obviously thinking about sleep and flashbacks. And whether they are infibulated, that will be after pregnancy. This will be in the adult. Next slide, please. So examination, as we've heard from earlier speakers, is with a colposcope consent, a colposcope with light magnification, because it's very important to document in case there needs to be a court case. Again, the same about trauma and traumatizing a girl when they are examined, as we heard from an earlier speaker. So it is very important to be mindful of what happened. And I do remember a girl, a few children had flashbacks when we examined them. So you have to be very mindful of that and very sympathetic and very, very careful. You can see how we do it. Will be two people and somebody, well, the mother in orange, and our play specialist with the adolescent who didn't want her mother there, distracting her. And this little girl and the adolescent in the picture are volunteers and nothing to do with the clinic, but they were happy to be photographed. Next slide, please. We have a discussion afterwards, think about whether they need to see the psychotherapist. And I'm sad to say many parents have been traumatized by the whole procedure, by the attitude to the school, attitude of the social work and the police, as we've just heard from Natasha, not quite the same at all, because this is a one-off event in the very different circumstances, but it's really about attitude of professionals and how people are treated. And particularly when the children come to the clinic and we find they have not been cut and it was a false alarm. And so parents feel very bad, very badly accused, and not a very good experience at all. We do BBV screening, as I said, and reports as appropriate. Next slide, please. And so again, we published the findings from the clinic. In all those 5 years, there were 148 children. And what I think is very important, and the second message to you, first message is how do you ask about FGM and who do you ask? And the second message is remember over 55, so 37.2% of the 148 children, only that number had FGM. All the rest didn't have FGM. And so that's a very important finding. So when you suspect, when people say, when people refer with a presumed diagnosis of FGM, don't assume that. It's really important that the child is asked, examined, so we know definitely A, that they've had it, and B, what type. Before, we've had a couple of children coming to the clinic who actually, I think there were two, who had been taken into care for some weeks because of concerns before we found actually they had not been cut. Next slide. So as you can see, we didn't have the numbers of children to warrant a weekly clinic. It stayed a monthly clinic. And you can see quite a lot in 2016-17 when mandatory reporting came in. There were more in that year, more like 40 children. But you can see here the orange column is the children who came and we found had not been cut, which is an important finding. And I think it points to the flowchart. And in Wales, you don't have this in your flowchart, but we do in England, that when there's a suspicion, it's really important that all these girls are examined by a paediatrician with the skills to do this, from everybody or our colleagues who are used to examining children with a suspicion of sexual abuse, because you're used to looking at the genitalia, because of the numbers where it's been a false alarm. Next slide, please. So you can see here that how in the cases where there was FGM, how do we find out? Most of the history was volunteered. Mothers told a health practitioner who asked them. There were a few prompted by teaching in the schools, as I've just mentioned, to the girls who wanted to be examined to find out what had happened. And importantly, 9 had a history of maltreatment. So if you think about your looked after children cohort, children you're seeing for physical abuse and neglect and emotional abuse, you must ask really more, even more important, have they been cut? Were they cut? Is this part of the maltreatment or something that they might want to disclose now they're out of the family and they know is something that has happened to them, was a secret that they weren't allowed to tell anybody, they can tell. Then we had 2 children were diagnosed because they had examination for other clinical indicators and FGM was noticed by the paediatrician. And 1 child was deemed to be at risk because of the travel history, because they'd been abroad and it was thought that they might have been cut there, and they had been. Next slide, please. So this is a graph, I won't go through this, about the people who raise concerns, and it's mostly the parent will say, and often doctors will note that it's been done. Next slide. And again, very similar to the BPSU, the first study I talked about with those results, very few symptoms, general symptoms in this graph B, and specific symptoms related to the genital tract in graph A. But again, pain, dysuria, pain on passing urine, although we might have attributed it to the FGM, we didn't know 100% whether it was due to that. So again, very few long-term symptoms. These are not acute symptoms. Next slide, please. So what did we add in this study to knowledge was that, again, it was much lower than expected. Most of the children had had it done before coming to the UK. In other words, they weren't sent out of the UK to have it done. And as I pointed out, very important in your looked after children cohort to consider it as something that's happened to them, more in comparison to the non-looked after group from practicing communities. Next slide. We again found evidence of medicalisation, as in the BPSU study. As we know from the UNICEF studies in Africa and worldwide studies, there's much more medicalisation, much more likely to be done in a health centre. It's also much more likely to be done at a younger age, so the child doesn't remember, so they're less likely to be caught, because in vast majority of countries, apart from now about 3 or 4 countries in the world, it is illegal. So doing it younger is much more likely to be hidden. Type 4 is really hard to identify, as I said, because often there's no scar. We noticed the parents' view and in children who hadn't been cut, where there'd been a misunderstanding and they had been referred to social care, and the whole procedure had been sort of started of investigation. And the number of children who didn't have FGM, over, as you saw from the statistics, over half had not had it. So it was lucky that they came to the clinic to confirm what the parents were saying, but actually not believed. Next slide, please. So as you can say, this is the group with no FGM, 60%. And some of them had 3 had minor gynecological conditions like labial adhesion, and the nursery thought they looked odd. Some of them were referred because there was a parental dispute and one parent said the other parent was going to do it or had done it. and 2 were in foster care, which was a sad story of 2 children who were taken in foster care but actually had no FGM when we examined them. Next slide, please. And often from non-clinical settings, so beware, schools, childcare facilities, foster children, foster carer suspecting, not children who are looked after who then make a disclosure, but when the foster carer suspects, they're more likely not to have had it. And then anonymous informants, sort of parental disputes, matrimonial disputes, because that can make it very difficult for the parent if they're accused of FGM and the investigation starts. Next slide, please. What I hinted before, and what we found, that parents' fear and shame being exposed, marginalised, singled out, the child being taken away, sometimes they felt they were treated like a criminal, discriminated against and scapegoated. And these are in both groups where there had been FGM and perhaps it had been done before they came to the country and it wasn't illegal from the point of view of our current law, but also the ones where it hadn't happened. So it's very important that one doesn't re-traumatise the parents when we're examining and seeing these children, whether it's in the multi-agency work or in the work of the paediatricians. And the next slide tells us what the children felt. Next slide. They were fearful of being examined sometimes, so very important to be child orientated, child friendly, let the child control the examination, explain what's happening. But some children, as you can see, very pleased that they're normal and the examination is very helpful, and other children, and they want to know about themselves, but other children don't want to be examined. Mostly the children who refused examination were in the adolescent group. In fact, they were all teenagers and they just didn't want us to examine them. Next slide, please. So just in summary, I hope you have a little sort of whistle-stop tour of FGM and know what the signs are. In other words, if you see genitalia that looks a bit odd, just ask for a second opinion, which I'm sure you all do in the SARC. Second point to remember is just remember to ask. People don't mind if you ask in a sympathetic way, and check out first, do they come from a practicing community? Don't assume just because they're Black African, they've all had FGM. And the third point is, when there is a suspicion, which is what we're all being trained to do, and schools are very mindful of that, just be careful that it's not a false positive, if you like, and the child, when examined, has not got any signs. Thank you very much.
Thank you, Deb. I find that really informative. Thank you very much. And I know that there's been quite a few questions put into the chat bar as we've been going through. I haven't been able to keep up with the conversations because I think there's been quite a lot of conversation going on. So if there are any questions for Deborah, if anybody would like to put their hands up at this time and can ask Deborah the questions that have been put in the chat.
Yeah, that would be helpful because I can't really whiz through the chat as well. Yeah. So do ask.
Is there anybody? No, I'll go through the ones that I can see then. So there's a question, do you have many medical students from FGM practicing communities? Is it addressed at med school, and do you have staff from FGM communities?
Yes, we do teach in University College London Medical School. They do have a lecture on FGM. There are students from practicing communities, yes. When I think with the lecture I've given, thinking about the audience and where they come from, doesn't mean to say they've had it, but they could have done. And certainly I've worked with nurses who have come from practicing communities and have told me they had it done before they came to this country. Your third question was about colleagues, I think, who come from practicing communities. Well, I've actually retired from most of my work now, and I'm just doing a little bit of work post-retirement, and the person who has taken over the lead in the FGM Children's Clinic at University College Hospital, the paediatrician, is Dr. Zakaria Ali, who comes from Somalia. So he very much comes from a practicing community. And he's doing the clinic with a paediatric gynecologist, a woman. So when you think perhaps the adolescent girls won't want to be examined by a man, it's probably correct, but there is a woman, there's CNS, a clinical nurse specialist is a woman, as is the paediatric gynecologist. But having a paediatrician, a man from a practicing community, because he's Somali, is, I think, very, very important.
Lovely. Thank you, Deborah. I've just had a look through the questions now, and they seem to have been answered as we've been going through through your talk about posters and further information.
Does anyone want to talk about any cases that they've seen or had experience with in Wales? In the BPSU study that I talked about, there were 6 cases from Wales that were notified to us.
Is there anybody you'd like to discuss?
Hi, sorry. Oh. Hi, it's Catherine here. Thank you so much, Deborah. It was a really valuable talk. One thing that I found tricky is that balancing of the report with the type 4s. Without sort of giving too much detail, had a young person who had some very vague memories, but was from a practicing community, but had a normal examination. And something I sort of found quite tricky was sort of trying to balance out the sort of statements to say, you know, maybe a type 4, you know, given that they've got some of these memories of something potentially having happened, you know, could they have experienced type 4 and not had a, but you know, obviously not been left with any physical signs of it. And I think that's quite, I find it quite a tricky thing to balance out in how I sort of gave a statement really of, you know, hypothesizing.
Yes.
But
where was she from and how old was she?
Oh gosh, I can't remember where she had grown up to be. It was a little while ago. But she was 14, but she had memories from something having happened when she was sort of 2 or 3.
Yeah. I mean, I think there's several aspects of that. One thing is I think it is important to explain to the girl, because if you always have that puzzle at the back of your mind and you don't really understand it, it's quite therapeutic and reassuring in some way to explain it to her. I would suggest that if you can't guarantee, but it sounds like that might be something that was happening when she, you know, 16 years ago to girls of 2 in that country, and you know that at that time X% of girls were being cut in this way where she came from. And so it's very likely, but what is reassuring is that actually she looks 100% normal like every other girl, and you would never know unless she told you. And so from her point of view, that's educational and reassuring about her own body. I think you were actually asking me about your report, is that right?
Well, oh, sorry. Yes, yeah. As I say, I think it was just thinking of sort of a quandary of how best to balance. Yes,
I mean, I think there's 2 aspects. One is about the girl herself and educating her, reassuring her, and you know, explaining, which is really important. And then, of course, her siblings and cousins. But in your report, I would say I think you can be honest. I think you can look at where the country she came from, look at this, and where, you know, the chances of it have happened. I mean, you could ask her parent, obviously, and then just say, because she had this memory, although you didn't find something, it's highly likely that she had type 4, but this has absolutely, and be very clear that it has absolutely no consequences for her future. And you're absolutely assured that she's got no intention of doing it to her girls when she, in X number of years' time, has daughters, possibly. And because I think that's really important to put that in a letter. Otherwise, she's always somehow labelled as a problem. So I would just be honest and explain everything so there's no misunderstanding. And it's not illegal because she had it presumably before she came to the country. So again, yeah, nothing for the police and social care to do. So that's also really important for the girl. She knows that if she does tell people, nothing's going to happen.
Oh, Catherine, I think you're on mute.
No, thank you.
Oh, thank you. Thank you. We've had a comment in the chat bar about language and language that's used when describing somebody, a child who's had FGM or somebody who's had FGM, and that ensuring that the language we use isn't referring to normal and abnormal presentations, and also that we need to state that it is a practice that's mainly carried out by women, although it's steeped in patriarchal ideologies around how women and girls should be, including ideologies around purity, virginity, and marriage. So that was just a comment from Maya.
Yeah, I think that's really important. And I did, as you remember, list the reasons for it and the role of men and how, as you say, you're absolutely right, although they're actually not involved in it. And I think part of the education is to educate men and empower them to think about it in a much more educated way. The other thing about the language is important because most people now in the world would talk about cutting and not mutilation, because it has quite a negative connotation, mutilation. Of course, some of the types that do cause mutilation, but as you saw from the diagram, type 4 doesn't. And I think it's better to talk about when you ask, have you been cut? Do you know what I mean? Have you read about it in the papers? Because then it helps the conversation. So your point is really valid. Thank you.
Lovely. Thank you very much. And I think unless there's anyone else who'd like to ask any more questions. No? Okay, lovely. Thank you, Deborah, and thank you for answering the questions and continuing the discussion with us today. That it was really useful, as I've said, and I found it really informative. In fact, I found the entire day really informative, especially as a non-medical professional. So thank you, and thank everybody for their presentations and contributions today, both for attending and for attending the day with the reschedule at short notice from an in-person event to an online event. We are hoping, we are planning on rescheduling an in-person event. The date is to be confirmed, but we are looking at July for the in-person event. Just a little bit of further information about today. So all the resources, links and video recordings, excluding Natasha's, oh sorry, am I saying July? June, sorry. Thanks, Andy. All the resources, links, video recordings will be shared on our webpage, excluding Natasha's contribution following the event. We are looking to establish a community practice and peer support network as part of the Welsh Sexual Assault Services programme. So if you are interested in being a part of that, I think that Andy will post her email address in the website. In the chat bar, and we'll be in touch with you at a later date around that. So it's just for me to say now, diolch I chi gyd am ddod i'r digwyddiad. Thank you very much everybody for attending today, and I hope you enjoyed the event as much as I have, and thank you to everybody as well for to the team for pulling it together and making the last minute changes for us to go online today and keep the event date. So thank you all, and hopefully we'll see you in June. Thank you. Bye.